Hello, my name is Alejandro Villagran, and my disorder is on post-traumatic stress disorder, also known as PTSD. So some information on my patient is his name is John Smith. He is a Caucasian male, 29 years old. He is recently divorced and he was a former military veteran where he served active combat for 8 years. So some information on his family is that he only has one sibling, which is a 24-year-old sister. He has divorced parents, and his father and uncle have history with other disorders such as depression and alcohol abuse. So some symptoms that my patient suffers from include intrusive symptoms, where he frequently has nightmare every night about his combat experiences. He's also reported having vivid flashbacks, which are usually triggered by loud noises. He also shows intense distress when he recalls traumatic events. He also has avoidance behaviors where he avoids crowds in hospitals. Anything that relates to veterans, he usually avoids. He avoids crowds mostly because of the loud noises. And he also has a really bad negative alterations in his mood. So he reports saying that he feels detached sometimes, which contribute to his emotional numbness. He also says that he has a persistent survivor's guilt, and he used to enjoy hiking and guitar and playing the guitar, but now he's lost interest in it. He also has hyperarousal symptoms where he scans the room constantly. He always looks out for exits and so on. He also shows irritability issues, and he also has been diagnosed with chronic insomnia. So the DSM-5 criteria for PTSD is divided very specifically. First, you need to have to had some exposure to trauma, which in John's case, he was exposed to direct combat. Next, you need to have intrusion symptoms, which is true for John since he has these reoccurring nightmares and flashbacks. Next, you need to have avoidance symptoms, which is true for him since he avoids hospitals and crowds. And then he also needs to have negative alterations in cognition or mood, which is true for him since he has these anger outbursts. He also needs to have hyperarousal symptoms, which is true for him since since he suffers from irritability and hypervigilance, and his chronic insomnia as well. Also, the duration for these symptoms have to be greater than a month, which is true for him since these have been present for him for over 2 years. Also, these symptoms have to have some type of functional impairment. It could either be social isolation or unemployment, which is true for him since he's currently unemployed. Something to know with this patient as well is that he doesn't show any dissociative symptoms, but he has delayed worsening after his discharge from the military. So some prevalence and age of onset with my patient is usually the lifetime prevalence for regular civilians or someone that isn't a military veteran is 6%. But that dramatically increases if you are a military veteran, which goes up to 23%. So the typical onset is usually 3 months after the trauma, but it can be delayed in some special cases, such as is the case with John here. So my main assessment that I used was a clinical interview. Uh, I did a clinician administered PTSD scale for DSM-5, which is also known as CAPS-5. CAPS-5 is known to be like the gold standard for treatment for PTSD. It's a 30-item interview where the person that's being interviewed takes a um, is assessed on his symptoms, which is 20 DSM-5 PTSD symptoms, and each system is rated on two scales, which is based off of frequency and how intense the symptoms are. So the scores are usually ranged 0 to 80, and typically a score of 20 or higher indicates PTSD. So in John's case, he takes the CAPS 5 and he scored a 58, which is on the range of severe signs of PTSD. So some psychological factors that could have gone into his PTSD is obviously his exposure to the traumatic event, which is the exposure of the environment of being in military and combat. In combat, he's been in multiple gunfights and he's seen the death of his fellow comrades. Another factor could be his maladaptive coping mechanisms. He's reported saying that he's been binge drinking a lot, mainly because he wants to numb the emotions of the symptoms of PTSD. He also shows catastrophic thinking, saying that he always feels unsafe and he always feels that anyone he comes across to he cannot trust. And obviously he has his survivor's guilt, which also contributes to his PTSD worsening. So some social environmental factors is his unemployment. Because he is unemployed, that financial stress that he feels enhances his feelings of worthlessness. Also, obviously, his combat exposure in the military, where he was forced to take multiple deployments without any rest, and also his lack of social support from his family, uh, which mainly was caused because of his irritability issues. So some biological factors that could have also played into his PTSD is his family history. His father was diagnosed with depression after his divorce, and also his uncle has been diagnosed with alcohol use disorder as well. Another biological factor would probably be his inadequate sleep. Since his trauma with PTSD, he hasn't been able to sleep, which also contributes to his emotional dysregulation. Another neurobiological factor that we saw in John is that he has a dysregulated HPA axis, which makes it harder for him to suppress his fear under safe conditions. So some comorbidities that come with PTSD is usually depression, anxiety, and substance related disorders. His most common disorder would probably be his alcohol use disorder, where he binge drinks every week. He also has a major depressive disorder, which is his persistent sadness and generalized anxiety disorder, where he always worries where he um, will lose control over himself, or he worries that he'll hurt someone. So for some treatment for John is first things first. We want to reduce his alcohol use. We want to be able to stabilize his mood better, and we definitely want to improve his sleep. So the main treatment I use is considered to be gold standard for PTSD, which is primary evidence-based treatment. And the one I went with is called prolonged exposure therapy. So, prolonged exposure therapy can be done over 2 weeks, and it also can be done over 8 weeks. But a case study shows that the results for the 2 and 8 weeks are usually not that different. But for John's case, I think we're gonna try and do a 12-week treatment since his PTSD is very severe. So how prolonged exposure therapy will work with John is that first we want to expose him to his least distressing avoidance behavior, which is watching a war documentary, and work our way up to the highest, which is visiting that veterans hospital. We also want to combine this treatment with medication. So we are going to prescribe him sertraline for his mood for PTSD, prazosin for his insomnia, and naltrexone for his alcohol cravings. So the results from the treatment is after a year, he says that he has been having fewer nightmares. Also, we made him take the CAPS 5 score again. It went from a 58 to a 35, which is a 40% decrease in severity. He's also reestablished connection with his sister and is now receiving support from her sister now. Her sister takes him to his group therapies, which he says now he feels less alone. And his alcohol use has gone from binge drinking to 1 to 2 drinks a week. And and because of all of these um, better treatments that he's received, he now works part-time at a homeless shelter. So that concludes my presentation. Thank you.